Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Saying that out loud is still funny to me. It makes it real.
Did we really pick that name?
We did. Yes, we did. And we did because we want to have fun while we're doing this. We want to be entertaining. And, of course, we also want to be relevant and informative. It's like party in the front, business in the back, like a mullet, only reversed.
Which is exactly how I explained it whenever we sketched out the purpose of this healthcare podcast. So that's kind of our MO, right?
Yep.
I'm Ellen Brown.
I'm Justin Politti.
And I'm Dave Pavlik. We are passionate, innovative, and collaborative, and we are committed to solving some of our industry's most pressing needs along with our clients. And we have a combined 90 years experience in healthcare.
This makes us sound so old.
I know.
I know.
In each episode, we're going to dig into a hot healthcare topic and dig into each other a little bit.
Please be gentle on me, guys.
You be gentle on us.
No way.
So we're recording this series of podcasts at MMG Studios down in sunny Tampa, Florida. And today we're talking about value-based care.
The big VBC, or you could say value-based contract.
Yeah.
So why are we in Tampa? Because we dropped our kids off in college last night. But in our first episode, we talked about that.
Yes.
But our kids did come to dinner last night.
I was so surprised. It's like they dropped them off at college. It's like, this is where you
Because
say...
Uncle Dave was there, which is you.
I know. Supposedly, they wanted to have dinner because they wanted to see me. I'm not
No,
sure.
literally, Dave.
I'm not sure I buy that.
I texted my daughter and said, Dave is flying in. And she was like, Funkle Dave's going to be here. I have to see Funkle Dave.
I'm the fun uncle.
Yeah.
And it really upset you that we hadn't cut the cord. So our kids did come to
No,
dinner.
I just thought, I remember dropping my kids off at college, and we were so angry by the time we were done moving them into their apartments, and then they blew us off. We're like, why are we even here?
Yeah, we had the opposite.
Then we just hit the road.
Yeah, so Sophia and Will all joined us. But so at dinner last night, we talked about, right, so when we talked to some clients about doing this podcast, we joked, somehow Cards Against Humanity came up. And our client said,
Yes, this is how we roll with our clients. We talk Cards Against Humanity.
We didn't play it with them. But then they said, hey, you really should do that at like an intermission of your podcast. And I'm all for it. And I know you guys are not. Hence, we are not doing Cards Against Humanity today. But I'm putting it out there because people might. I don't know how many people will listen to this. But if they do, we'd be curious to know who wants to hear it.
A lot of people are going to listen.
Yeah.
It's going to go viral.
I actually told Ellen she needed to run it by our producer, Kim. And she said she would, but she forgot.
But I didn't.
She
Maybe
didn't,
that was
you knew
like
she was going to say no.
It was like a Freudian slip.
The challenge is, honestly, the funniest stuff is so inappropriate.
So wildly inappropriate. So we played it last night. We tested it last night at dinner with our children.
And we won't get into the inappropriate things that happened, but
you proved your theory right, because everyone that was picked was the most inappropriate and most wildly inappropriate, right?
So you'll be glad we're not.
Okay, so
doing
if
that
anybody's
today.
listening to this and they understand and they want to see Cards Against Humanity, but
We have to do the
understand
clean
how
version.
correct. But we tried that. I bought the family edition, and everybody thought it stunk.
Ooh.
It was
Yeah,
no
it
fun.
boring. The boring button.
Okay, right.
Boo
So we
birds.
do have a sponsor for this series of podcasts, P3 Health Partners.
Yay!
Yeah. P3 is a population health management organization founded and led by physicians with a strong background in value-based care. Contact P3 to find out how they can help you improve outcomes, lower costs, and help enhance the health and well-being of your patients. People, passion, purpose. That's P3. You can find them on p3hp.org.
Shout out to P3.
Yes.
Thank you for giving it. It makes us sound so legitimate. So we're up for sponsors for our next round, right? Okay. All right.
So,
Today we're going to talk about a subject near and dear to my heart, value-based contracting. It's supposed to be the white knight of healthcare. What do you think, Ellen?
The white knight. I actually think value-based contracting or value-based care has been like watching paint dry.
which is the opposite of this podcast because it is so dynamic. People are stay tuned.
So we're going to dig in. I'm going to ignore that. We are going to dig into why VBC is a great idea, but why we are not there yet, and when on earth are we going to get there?
And how?
And how. And what we think, because this is our show. 90 years of experience. That's why. So with value-based contracting models, we go back into the history, right? And they started as early as the 1960s, but the term really hit stride.
60s, value-based care?
Yes,
Okay.
yes, it's legit. It's like 1967, and it was an early version. I'm putting my geek hat on. It was an early version of the primary care medical home model.
Wow.
So I just had this vision of Jimi Hendrix, Jim Morrison, Janis Joplin, much like us, around the table.
You can't even put us in the same category.
There's beads and incense. There's a lot of stuff that's going on.
I'll go with the incense.
Right. But I think they collectively solved value-based contracting.
Okay.
But each of them met their untimely demise at age 27.
So we lost 50 plus years.
So, and we've been left trying to pick up the pieces since then. There's this big gap. So that's my...
What about Paul McCartney? Paul McCartney, I think he was
He's still alive, though, but...
This is my Liverpudlian accent. He's like, hey, we've had value-based care forever here in Liverpool.
Well...
It's
No,
free.
we're not going down the socialized medicine.
Care is free. How's that value? That's
I'm
value.
talking America.
Okay.
Yeah,
Those are
yeah,
three
yeah.
American...
Okay.
We're not talking socialized
Right.
medicine, Dave.
You're
That's
not.
for another day.
All
Okay.
right.
So you asked me about the white knight thing,
Yes.
right? And VBC really is kind of the white knight for saving the solvency of the Medicare fund. I mean, if it isn't VBC, some other white knight better be coming really fast, because it's kind of like other things that we act like they're not happening, and they're like happening every second of the day.
But why isn't it evolving fast enough? Why is it taking so long?
Well, just like everything else, the administrative complexity that you get into when you look at the details is what's slowing us down, right? The nuances, and I say we could really blame our founding fathers for the setup that we have, in that we've got 50 different systems of administrative levels, every state, every local community. It's different, right? So you kind of have to tailor your model to each market that you're in. And that takes a long time. And to be honest, people, they would rather try to come up with a one-size-fits-all application that really doesn't do anything.
But that's at the payer level, right? That's the issue, is like the payer's trying to do a one-size-fits-all, but then the local market has its own dynamics. And then, I mean, we could go on and on. So I asked, I'm cutting you off, because I can push the boring button. No, it wasn't boring. That was actually not boring. But so I had lunch with somebody recently. It's not a secret, but I won't say any names in case he doesn't want to.
Does Brian know about this?
No, he doesn't. He could. It's fine.
Okay,
It was just lunch, talking business. But it was actually a really good conversation, because this person is in value-based care and is actually working for a cardiology VBC organization, where they're trying to figure out the business model of bringing cardiology in the mix. We're going to talk about this whole piece in a second on specialty care, so I won't go ahead of the game. But I asked him, I said, okay, tell me what you think is a barrier to VBC, right? Like, tell me what you think is the problem as to why your organization is not getting the traction that you'd like to see. They're not failing or anything, but it's not like some easy thing. They're getting critical mass, and getting a voice is challenging when it comes to VBC in specialty care. So if they want to be a convener, you got to get a lot of momentum behind that. And he made a really good point. Again, these epiphanies to me are always like the simplest things. But what he said was, one of the major barriers for transformation was that we gave too much away in the beginning without asking for enough accountability. We were so excited in the beginning, like, oh, you'll do VBC, I'm going to give you money, right? I'm going to give you money to do this, and I'm going to do money to do that, and all this. And we gave all this money away, and yet we didn't have the systems in place to track it. We didn't hold people accountable. And now it's like casting a line and then trying to reel it back with there's nothing on it. Like, you can't go backwards once you've gone forward. So
I agree. And we have another client who similarly rolled out a very innovative program, but wasn't able to, or didn't roll out VBC along with it. And so basically the market is getting that innovation for free.
Yeah.
And, that's what's got me most concerned about the direction that we need to change the trajectory of where we're going, so these types of things don't happen again. Because otherwise you're going to wind up killing things that, are really change agents in the markets. I don't know, Dave, what do you think about?
I just think it's lagging way behind. VBC adoption's lagging way behind. All the different models that are out there, like you said earlier, makes it way too confusing.
Well, they're overlapping, right?
Overlapping,
That's the problem
right,
too,
exactly.
is that like there's only a limited amount of funds available to share. And we've given out, in essence, we've built a model that would give out way more than we would ever save.
Yeah, it's
Right?
confusing, and it dilutes the effectiveness.
Yep.
Yeah, and so the industry has basically rolled out these programs that focus on quality measures, kind of what I'd say affects things around the edges. Everyone wants to improve quality, and it's better than where we were in just a straight fee-for-service environment. But we've got to evolve to a point where, as if you've got an innovation, like you're able to have the discussion with the payer with a business model that shows that you're reducing savings, but you get compensated for that up front. But that doesn't mean that you're not responsible for your performance. If you perform poorly, then you have to give some of that money back.
Which nobody wants to do.
They don't, but this is where
nobody wants
That's
to
what they sign up
to
for.
go. Well, but they don't.
Well,
That's
when
the
they do,
problem,
though.
right? But it's like eating cut glass sometimes to get people to want to. Right? It's like, oh, I'm going to do value-based care. Well, oh no, I need a little bit longer. I'm not ready for that.
And then the actuaries come in and everything stops and grinds to a halt, right? So
you need an IBNR of 156%. So
right.
yeah, no,
So-
it's a mess.
So there's all these different layers. And then we have what is an effective tool with PCP capitation. You've got many groups who are very effective, particularly in the Medicare Advantage space, in managing populations, but it's just PCP capitation for those small, it's for a smaller universe. We've got to expand way beyond that. And not everybody, that's not the right fit for everybody as well. But we've got to bring in specialty care in these high cost areas to be able to focus like on
Right.
unique components for each of those.
And that gets into this kind of second piece. It's all connected, right? But it's payment transformation. So if we're going to truly do payment transformation, we can't just look at these very fragmented elements of the system. And before we kind of talked through for this podcast, I had this belief that, we were being really integrated. We were looking at total cost of care and things like that. And then when we sat down, right, and the three of us started talking about it, I realized we really are not doing it at an integrated level at all. And I think this gets into, we've been traditionally focused on primary care. And primary care is absolutely the most critical component to all of this. But it's also primary care at a little bit more of a functional level, where primary care is truly integrated in with specialty care, and it's not. And then the specialists are all out there still kind of doing their own thing. And to me, that's one of the biggest issues here. And then to your point, Justin, we have these more innovative approaches now to specialty care that are really emerging, and we're working with some of them now. It's very exciting stuff. But so many of them, their success is predicated on cost avoidance and not cost savings. And to me, that's a really important differentiator that we can even talk about a little bit more today, which is in payment transformation, if we're going to move from fee-for-service to value, then if all we're talking about is cost savings, it's really an impossibility. We have to also factor in cost avoidance. And we talked about this before, right? This is like one of the biggest conundrums in healthcare today is how do we, it's like risk. It's like, I don't ever want to take risk. It's like a dirty word. And I feel like cost avoidance is starting to become the same kind of moniker.
It is, because they have to invest up front.
Right.
And maybe they'll have cost avoidance, but maybe they won't. They've
that's
got to do it right.
Right, but they're never going to see it the way that we traditionally. It's like we have to break the system. It's like we have to break the construct of cost, right?
So, and what I'll say
And then
is this,
fix
I
it
got to
again.
take us down the road, but there are a whole host of skeptics about this topic altogether. And there are still many of them within the industry that we work with on a regular basis who don't necessarily buy into the fact that value-based care is what's they're wed to the fee-for-service model. They're not a convert, right? They're living in their own universe and are totally fine to a certain extent.
But can you blame them?
No.
I mean, how can we blame anybody for
And
staying
I have
in
to
it, right?
make a confession. In the very beginning, I'm going to say this.
Here we go.
I'm a convert. I was a skeptic in the beginning. I did not believe that we would get even as far as we have, just given how ingrained and simple fee-for-service reimbursement is.
Well, it has been 60 plus years, so.
Yeah, but we haven't changed the systems. I mean, how many times, this drives me crazy. You drive down the road and there's these big billboards and it says, how long is the ER wait time, right? And then it's like, we get angry if the ER wait is 2 minutes or something, right? We don't want to wait in the ER. What am I supposed to say? The emergency room. The emergency room. But then you go there, and that's the other thing. It's like a one-upsmanship of whether it looks like a hospital room. Like you go in and you're in a hotel. Oh, I said it.
And she is. ER and hotel.
Instead of hotel. There,
right,
I said it. Hotel. You go in there and you want to be catered to, and yet we don't want to pay for the cost of that. So this is what drives me crazy. We, as consumers, and in the healthcare industry, we've created this expectation of how are we going to attract everybody to our beautiful facility, right? But we need to be saving money. So we can't just keep it's like the incentives on VBC. It's like the free money that we gave out. We're building all this cost into the system because we want to make the consumer happy. We want them to come to our health system. But the reality is that there's too much capacity in the wrong places. We're putting too much money into something that can't be funded, and then we ignore cost avoidance. But the thing is, if I put my hospital system hat on, and I'm in a market where I can keep charging what I want, and I can keep churning out volume, and I can stay profitable, why do I want to move to VBC, Justin? I mean, right?
But the thing that ultimately converted me, and I had to really have a long talk with myself.
Wow. I don't know,
Justin,
Dave. Do we want to go down this road?
Let's go
right,
on, Justin. Let it roll.
I would like the self-conversation.
The reality was I said if I was to start the whole healthcare system all over again, having no history whatsoever.
But you did this with yourself.
That was
Was it
a long debate. It was 3 o'clock in the morning.
Yeah.
Those things.
Oh yeah.
And to just come to you. I basically said there's absolutely no way on earth that you cannot have some kind of value-based premise for everything tied to outcomes. And we need to get to that point and away from the fee-for-service system that we have. I would not start with that. And so if that's my underlying belief, then how could I stand back and just continue to let fee-for-service run, rule our country?
Okay, so Justin, we have an overlapping system. We have promised too much money to too many different stakeholders and have not connected the dots, right? We haven't connected the outcomes. We haven't made the contracting terms similar. And I know actually CMS, under the new Making Care primary program, they've held some stakeholder sessions, and they have actually, for once, shown, not for once, but they really are showing that they want to convene. They want to be more of a convener, right? Mm-hmm. So we need conveners that more standardize what these programs are, but we know what these challenges are. So I'm going to put my specialist hat on. So now I'm a specialist, and I'm standing out here saying, how do I become part of this, right? Because I see no reason why I should. I'm getting my fee-for-service money. Nope. And anybody that asks me into the value-based tent, they just want me to come in for free or take some kind of a discount.
Yep.
And then maybe get a little prize on the side, right? So, but to your point, I'm reading it all in the industry journals, right? And I'm like, oh, I better do something. So what do you say?
I say, back to my earlier point.
Sorry, Dave, we're not asking you very much today.
That's okay. I'm enjoying this. It's one of the reasons
moving
why our
somebody
clients love us, because we have these differing
And you can just
opinions,
watch
and you
it,
can just like back and forth,
bing,
ping
bing,
pong.
bing, bing, bing.
Yeah.
At least when you have to
We
hit
don't
the
always
boring
agree.
button.
We don't always
You
agree on
wait,
things.
You get to hit the boring button today. You haven't hit it much.
Yeah, and it'll
No,
be
I'm-
coming soon. I'm not sure if,
Yeah.
if I
We
have
have to
more talks
custom
with
order
myself,
one.
that's,
All right.
that's going to
I'm
get very
very-
boring.
I'm
That's
very-
a strange button.
Yeah.
I'm
Okay.
very
We're gonna have
intrigued.
multiple buttons. All
But
right.
back to answer your
my
question, it goes back to this aspect of like, what's compelling enough to a provider to move them from where they are
And to the payer.
and to the payer as well, right? So if you're able to get upfront payments and then tie them to future outcomes, and then guess what? You have the ability to make more than you are under the fee-for-service system if you're performing well. But if not, there has to be that tie back to, and let's be honest too, though, when you're talking to providers, they are very focused. Like, how many times have we been in provider with clients, how focused physicians are around their performance and how they compare to their peers?
Yes.
Now, they will pick it apart if it's not accurate, deservedly so.
That's what I was going to say, because that's the rub. Those outcomes, there's not a universal set that
No.
that they can trust
can-
and believe.
But we've got to get there, right?
Yes.
Meaning, like, yes, there's always going to be some degree of, back and forth on the accuracy. We've got to get ourselves
I
to
hear
a point.
another episode.
We've got to get ourselves to a point. So where do we go from here? I think, and we've been talking about it, we've got to develop compelling value propositions.
For both the payer and the provider.
Yep.
Okay.
Specialty providers really, as we talked about, need to meaningfully be at the table
With the payer.
with the payer. Here it is, upfront financial incentives.
That's
And
a tough sell.
It is, but
We're doing it for the primary cares.
but we've got to move beyond that.
Yep.
But we also cannot be boiling the ocean, right? We've got to get, because that's the other thing that's been everything is just too broad. You need to consider the markets that we talked about earlier, right? And the fact that things are unique in each market, and you narrowly define what success is. It's not like 80 measures, and it's not 80 outcomes.
and
things.
you know that I like to do
I
that.
know. Yeah, well, Ellen and I will debate.
Come
we
on,
could go
Ellen,
down.
That's not implementable.
Usually I start at 1 and she starts at 15 and we end up at 5.
We have to make sure that we do this, that we do
Right,
this, that we do this.
So that one's in there for you.
You've converted me. You've converted me. I'm much more. But I say, in full disclosure, when we have these discussions with clients, I'm like, I would like a lot more, but the reality is it's too complicated, right?
It is. It is.
So I would agree with that. I would just say that the other thing, right, we've been talking I feel like this is very much a provider. I could be a payer or provider listening to this conversation, right? That's fine. But I feel like what you just described is very much, how do I, as the provider, sit at the table and become part of this conversation? But if I put my payer hat on, then I'm going to say, you know what? I need to have a Justin conversation with myself, right? And I need to kind of go back to the beginning and say, where is my VBC money going? And how do I eliminate the redundancy from my programs, right? Because right now, if I'm honest with myself, I'm giving too much away, or I've got too much sitting out there. Not that I ever will, because everyone will just argue too much about whether or not it's accurate, because that's what happens.
Yeah.
But still, all that to say, I really do, as a payer, I need to say, wait a minute, how do I integrate this and align it so that it adds up quantitatively to be as close to 100 as possible and not 150? And how do I make sure that all my major stakeholders, which isn't just the primary care, right? I mean, I would argue that we're talking about specialty today, but we really need to look at inpatient. We need to look at outpatient, and we need to look at the facility level. Like, this needs to be, from a payer perspective, it's a different conversation. So
It is, and it all goes back to what you're bringing to the table, right? And having your own unique value proposition be considered from a payer standpoint, right? But you've got to be organized in your approach when you're going to the payers.
Yes.
And you've got to be concise with, hey, we've done our research, we've done our legwork, and it's not just having a theoretical conversation, because that isn't going to go anywhere.
yeah.
So investing in that time and energy on the front end is, is the key. So,
All right. So I think we're like.
So what are the-
we need
what
to
are the-
wrap it up?
what are
No,
the-
we got to wrap it up.
Okay.
We did summarize it.
Okay.
But I don't think this is going to be in the podcast, just so you know. Okay. So thanks again.
Ellen
I'm
I.
Ellen
Cap-
Brown. Come on.
I'm
let's
Dave
do
Pavlik.
it.
And I'm Justin Politi.
We're the partners at BP2 Health. Your best chance for real change.
As you can tell, we can talk all day about healthcare. Drop us a line at our site at bp2health.com.
The Reverse Mullet Podcast is produced by Henry Street Media with Kim Rittberg and Emily Newman as producers.